All right, good morning, everyone who's joined. We're just giving it a few minutes to make sure folks can get on to this webinar, and we'll be starting in a few minutes.
Everyone, excuse me. We're going to go ahead and get started in just a minute. Rachel, I see you have your hand up. I'll let you ask a question. Did you have a question, Rachel? Okay. If you have a question, you can put it in the Q&A. That should be active. I can't hear folks right now. So we're going to go ahead and get started. We're really happy to see many of you here this morning. I know it's very early. Kelly and I are coming to you from the East Coast, so it is our lunchtime, but I know many of you are probably just getting your days started in Washington. Again, my name is Colleen Gibbons. I'm a senior program manager with the Center for Justice Innovation. We'll talk a little bit about what our organization does in a couple minutes. But I wanted to just introduce myself. I've been doing work in Washington State for several years now as part of a larger grant across the state. And one of the things that we are really happy to work on and to bring to all of you is this training on risk need responsivity. This is the first of several trainings and opportunities for involvement in what risk responsivity means and what it can look like in your courts throughout the state. I'm an attorney by training. I also have a degree. I got my PhD in human and community development. So I'll nerd out a little bit as we go through the slides on some things related to data and systems that I'm really excited about sharing. But really, it's exciting to be here with you and to be able to share this. And I'll let my colleague Kelly introduce herself as well.
Good morning, everyone. I'm Kelly Vandeveld. I am an associate director on the Recovery and Reform team here at the Center for Justice Innovation. I come to you as an attorney. My background is as a prosecutor. I worked in the Bronx as a prosecutor for about 7 years, and then joined the center to do the work that we're going to talk to you about here today. I've been working on risk need responsivity related trainings and presentations for the entirety of my time here at the center, so a little over 5 years. I'm really happy to have the chance to talk to you about the theory and how the interplay between the theoretical ideas of risk need responsivity theory and how that applies to your therapeutic courts and how you can use that to continue to do the work that you're doing with the populations that we'll talk about today. I also note that the chat is disabled for this webinar, but if you do have questions, please put them in the Q&A. We're going to try to answer as many questions as we can as we are going through the presentation, but we'll also leave time at the end for questions. And some of your questions may be more appropriate to save to the end of a section or the end of the presentation, but we'll try to make sure that we're getting to everyone's questions throughout this webinar.
Thanks, Kelly. I also want to acknowledge that our colleague Spencer, who has been also working quite a bit in Washington State with us, was unable to join us today as he is not feeling well, but we will cover for him, and he sends his regards to everyone because I know he knows some of the folks who are joining our call today. All right, so I want to go ahead and talk about our organization a little bit. So one of the things that we do at the Center for Justice Innovation, or I should say the main thing that we do, our mission is really around reimagining justice and working in communities. Our goal is to work locally, to identify challenges, to create and operate innovative programs to address those challenges both inside and outside the courts. Kelly and I, obviously, we're both attorneys. We're very familiar with treatment courts and therapeutic courts. And one of the things that really drew us to this organization and makes this organization unique is that we work within and without the court, right? Outside the court. So we're able to take that work in the court, and also we have teams that conduct and analyze field leading research that look at those issues and solutions. And then we share what we learn with justice systems, governments, and communities to really seed justice across the country and beyond. That's really what we are doing here today. Kelly and I are both on the recovery and reform team, where we come and offer expert assistance hands-on. We also are able to provide that assistance in the form of webinars so that we can disseminate information most broadly. And really what we do is be able to take some of these innovative justice initiatives that are happening across the country in New York City and beyond, and be able to explain to people how these projects are launched, how to get them off the ground, and then plan and implement similar programs in your communities. We can, again, do this in many different ways. It includes analyzing data, facilitating planning sessions, and hosting site visits. If you have questions about our organization, please feel free to ask them as well. Specifically in Washington State, we've been doing work for several years now and have multiple different programs going on, including pilot sites and different kind of strategic planning activities across the state. We'll go to the next slide, Kelly. So specific to this training, we know that people are interested in risk need responsivity. It's really a core of the way, it's a foundational core of our treatment courts. And so what we're going to cover today are ways to identify appropriate target populations for our courts, roles and responsibilities for folks as they relate to risk need responsivity. We'll talk about the background overview and appropriate use of risk need responsivity tools. And we'll share some best practices for high and low risk populations in therapeutic courts. So I know some of you registered really excited about this, and we're excited to share what we know with you, but we want to know a little bit about you. And so I'm going to ask you first, who's here? We want to know a little bit about you, what your role is in therapeutic courts, and then we also want to know what your knowledge is of R&R at this point. So please feel free to enter your info here. We'll kind of scan what people put in, and then we'll move forward from there. Hopefully this is popping up on your screen. Yep, I see people responding. That's great. So far, we have about 40%. Okay. Oh, so I think it might be, we're getting there. We have a few more people. All right. So we'll share our results, see who's here from the folks who participated. So far we see that we have some defense counsel, case manager, coordinator, treatment provider, some administrative folks, and other. The R&R looks really across the board. So for some folks, this is really new. Some of you feel that you know what's up with R&R, that you have a solid foundation, and some are hoping for some more advanced takeaways. So hopefully we can cover that across that spectrum and get you to walk away with some takeaways that will really help you in your therapeutic courts today as well.
And I'll
Thanks
just say that, oh, sorry, Colleen. I'll just say for those of you who are looking for more of those advanced takeaways, we are going to start with some of the really foundational parts of R&R theory. But I think it's always really important, as someone who does this frequently, I like to go back to the basics and really think about R&R theory in its most basic form, in the theoretical underpinnings of it, because I think it's so important that we're using the same language, and that we really understand those theories in order to then apply them correctly in our treatment courts. So hopefully this will be a good review for those of you who feel that you have more of an advanced knowledge in this topic.
Thanks so much, Kelly. All right, let's jump in. One of the things that I love to do when I'm doing presentations, and this comes back to kind of my nerdiness and background in working in systems, is talk about what systems are, because so many of us use that as common language. We tend to say, oh yeah, someone's involved in the system, or someone is touching the system. That person has been in the system for, their whole lives, right? But when we talk about it that way, we don't necessarily have a vision or an understanding of what that is and what that looks like. And so I love to share this model. This is actually called Bronfenbrenner's ecological model of systems. Again, very nerdy. You don't have to have that as a takeaway, but it gives you a visual that helps to really understand when we talk about systems, especially in criminal legal contexts. So we see at the middle of this, we have an individual, right? You can't have a system without a person, but then there's all of these other pieces that come into play for that person. And I like the colors and the images of what these different layers are. For the individual, the things that are closest to us, think about what your microsystem are. What are the people that you interact with all the time? Generally, that is your family system, the people around you, and then other things that you are engaging with on a day-to-day basis. In an ideal context, other systems like the criminal justice system, the child welfare system, the family court system would be more attenuated. It would be farther out. It wouldn't be something that is part of your day-to-day life. For folks that we work with in the criminal legal context, often those systems are much closer. Those are their microsystem. That is where they're involved. And in a therapeutic court context, our goal is to be able to move people away from having court as a key part of their life, to help them develop systems, smaller systems that are closer to them, and move that back out into something that they don't have to interact with on a day-to-day basis. And when we talk about changing people, places, and things, those are the things that we want to focus on when we're talking about those microsystems. This is just a really interesting way to kind of frame the way that we do the work that we do. And when we're talking about R&R specifically, we're talking about all of the people that have touched the system, right? That broader context, and then trying to help one person using the kind of aggregate data that we've worked with. Go to the next slide, Kelly. Another foundation that I want to talk about is something that many of you are familiar with, because this is really the foundation of our therapeutic courts, specifically our adult drug courts and treatment courts. So we'll reference over and over today the standards. The best practice standards, as distributed by All Rise, ground the work that is done in our courts in research, in data, provide context and best practices. Many of these standards, there are 10 of them, have been updated. We are waiting on updates for some others, but the standards that we're going to be referencing today are directly related to R&R and the work in our therapeutic courts, and are updated with best practices. We'll try to cite when we use those, but also we'll distribute a link to where these practices are found when we distribute this, when this presentation is available later. Go to the next slide. The other thing that I wanted to include, and this is a lot, is actually the definitions from the legal code around some words that we will be using today. So when we're looking at best practices, when we're looking at things that are evidence-based or research-based, there's actually definitions for those. So it helps us to understand the ways that the outcomes are reached and the ways that the things that we're reporting on are developed. So we want to use best practices in our courts all the time, right? That's the standards are based on those. And this gives us a definition for that. So based on statistical analysis or well-established theory of change, it can include a program that is evidence-based and shows potential for meeting the evidence-based and research-based criteria. Then we go in to say, okay, so what's evidence-based and research-based? Those are things that we, again, hear a lot, but maybe don't have the context to or haven't spent time to think about what that actually means in practice. So the definition of evidence-based is a program or practice that has been tested in these populations with randomized statistically controlled evaluations or both, or large multiple site randomized or statistically controlled evaluation or both, where the weight of the evidence from this systemic review demonstrates sustained improvements in at least one outcome. So that's a lot of research heavy stuff. It's not something that you are doing in your courts necessarily, but it is something that folks who are developing these best practices are very aware of. That B is really interesting because when you look at it, it says something that is evidence-based may be implemented with a set of procedures to allow successful replication in Washington, and when possible is determined to be cost beneficial. So maybe it's not the full hands-on statistically controlled evaluation, randomized trial, but it is something that matches or could be replicated in Washington. Research-based is evidence-based kind of light in the way that it's described here. So it's maybe a single randomized trial, not multiple randomized trials, or where there's a systemic review that supports the outcomes, but maybe isn't fully evidence-based yet. But these are things that we look at because often in our courts, we're seeing one or two people, right? But the folks that are doing this research and bringing us these best practices are doing this on a very, very broad scale. And so when we're presenting this to you, those are the kind of numbers and the research that we're bringing. Next slide, Kelly. So now we're going to jump in to our first takeaway. So identifying appropriate target populations. What does this look like in our courts? We'll go right into the next slide.
Okay, so we are going to have some examples throughout this presentation to start having you think about what risk and need means when we're talking about an individual potential participant. So we're going to start with some information about our potential participant. I'm going to have you meet Danielle. So Danielle was charged with possession with intent to deliver. She was found in possession of 2 grams of cocaine. And in this arrest, she had been given money by an acquaintance who asked her to get the cocaine. She purchased the drugs and while planning to use a small amount and give the rest to an acquaintance. So when I was a prosecutor, we'd call this someone who's doing a B&B that would keep one. So she's going to be giving most of the drugs to the person who asked her to be the middleman, but she will be keeping one to use herself. This is going to be her first felony charge. So our first question for you is, just knowing what we've given to you right now, if you were evaluating her for your program, would you consider her to be a candidate for an adult drug court? We'll let you guys answer that. Colleen, I can't see the answers coming in, so you let me know when we can move into what people are thinking.
Perfect. We're seeing some folks respond right now.
Great.
Okay. Any others? Last call for responses. I'm not sure is an okay answer if you're not sure. Okay.
Okay, so we're pretty split. We have 55% saying yes, she is a candidate, 32% saying no, she is not, and 14% saying I'm not sure. So we're going to continue to talk about Danielle throughout our presentation and give you more and more information to help build a concept of who this participant might be. And we'll see if any of that changes your mind. And we'll discuss how R&R theory, how we would apply R&R theory to think of this individual.
Thanks, Kelly. So we're going to talk about, again, the foundation of who we serve in our adult drug courts. This might look different depending on what type of court folks are in, but that's why we specifically targeted this presentation at adult drug courts in Washington State. So best practices, I'm again directly citing from there. This is the language directly from All Rise Best Practice. Target population says that treatment court serves high risk and high need individuals. We hear that over and over again. Say, oh, high risk, high need. What is that definition? Who are those people? So they must meet two prongs. It is someone who is at significant risk for committing a new crime or failing to complete less intensive dispositions like probation, and have a moderate to severe substance use disorder that includes a substantial inability to reduce or control their substance use, persistent substance cravings, withdrawal symptoms, and or a pattern of recurrent substance use binge episodes, which could include use that substantially exceeds the person's intentions or expectations. So those are the people that we want to serve in our adult drug courts. That is because we know the weight of the evidence shows that those are the people who will be most successful and really benefit the most from the programming of an adult drug court. We'll go to the next slide. So to be able to get high risk and high needs individuals in our courts, we need to figure out what that is. And it can't, and it shouldn't be just by kind of eyeballing someone, right? We can see, we already asked a little bit about Danielle, we'll learn more about her, but depending on what we know, we might say yes or no, this person is high risk or high need. So we need to use a tool. And often we talk about tools, we'll talk a little bit more about what that looks like, but in defining a risk need assessment tool, this is a definition that we tend to use, which is risk and needs assessment instruments typically consist of a series of items used to collect data on behaviors and attitudes that research indicates are empirically related to the risk of recidivism. I read that definition and I think, okay, that's a lot of big words and things that I know, but I also don't necessarily really grasp. And that's because the people that are doing this, the people that are designing these tools are researchers. They're looking at very large data sets to say what has happened in the past and what can that do to help us understand and predict future outcomes. We want to look at behaviors and attitudes that actually are shown to be related to risk of rearrest. So there are multiple tools. We'll talk a little bit about them later. But really, we want to look at and understand that when we use these tools, they're looking at things like someone's criminal history, really what their criminogenic needs are, and their basic demographic information. We've started to drop that a little bit about Danielle, and we'll learn more over time. That gives us that risk category. Then we also need to talk about what the tools look like and what maybe there's bias, maybe there's different things that we on our own might not identify. So we're going to be able to talk about these tools, talk about the way that they collect the data, and then how we can appropriately use them as we're defining who should be in our courts. So there are a bunch of different words that are used, and this actually is discussed in the standards as well. Sometimes we throw these words around. Sometimes they mean something different. Sometimes they mean the same thing. In the definition on the previous slide, we talked about a risk needs assessment tool. So we had assessment and tool. And then they said that they're instruments that consist of a series of items, right? So several of these words can overlap. Today, we're really talking about the ways that we're using these items, right? The ways that we're using these things to help us define risk need responsivity. So again, this kind of gives us that and explains it as defined in the standards. So they're often used imprecisely and interchangeably in our criminal legal system. It can be confusing to people to say, well, they've been assessed, but we didn't use a screening tool. What does that look like and what does that mean? So the thing that is helpful, and again, I'm going to keep referencing these standards, is that in the standards as they have been revised, it defines specifically that there are different types of assessments that serve different aims. So today we are talking about risk need responsivity screening and what that looks like. And on the next slide, we'll see where that falls. So what we're doing to be able to say we want to determine our target population, that's our eligibility. How do we know who meets this criteria? We're using these eligibility assessments to see whether someone meets a treatment court criteria for being high risk and high need. We might say tool, we might say assessment, we might say screening, but that's what that is. So when we're talking about that today, we're talking about eligibility assessments. Other things that our treatment courts use include treatment planning assessments, right? We know that someone can't benefit or be in a court without that. That is not a screening for high risk, high needs. That shows what the treatment plan is, what someone needs to be able to be in treatment, and that involves collaboration with that person for what best meets their needs. We also know that courts use screening assessments, right? Again, sometimes we use these words interchangeably, but when we're talking about screening assessments, outside of risk need responsivity, this is to say, what are other needs that the people that are coming into our therapeutic court have? That can include housing, that can include identification, transportation, other things that could come into play that could interfere with their treatment and their progress in that court. Then often we talk about outcome assessments. That's at the end when we talk about outcomes, right? That is saying, what does this look like as this person progresses over time? That again is not telling us who gets into the court, but is when people are already there. So this is that framework. It's very helpful. I encourage you to go to the standards to look at this, because again, often when we hear these words interplayed, it can be a little bit confusing. So again, today we're talking about what is our target population? How do we get people in? These are the eligibility assessments.
And Colleen, we have a question. Who often evaluates, i.e. screens someone for treatment court participation?
That is a great question, and we will get to it in a little bit because we're going to talk a little bit about roles and what that looks like. So we'll go to roles and responsibilities as they relate to R&R. So one of the things that we need to know is that everyone who is involved in therapeutic court should have a baseline knowledge of risk need responsivity. It doesn't mean that people have to be experts. It doesn't mean that you have to know the ins and outs of everything that Kelly is going to talk about later. I have done that presentation. I've learned about it. I feel like I have a very good knowledge of R&R, but there are times when I will even get tripped up on that, right? But everyone needs to understand some of the things that we're talking about today so we can know that we are treating the right people. The question response is that second bullet point. So from these standards, we know, and from the data that they provide, we know that the best outcomes happen when assessment and case planning are performed by professionally credentialed clinical case managers, a psychologist, a social worker, specially trained supervision officer, someone who understands how to administer and also what the outcomes are being read once that tool is administered. Treatment courts should ensure that their assessors are appropriately trained and proficient in test administration and interpretation, and receive at least an annual booster training to maintain their competence and remain current on advances in risk and needs assessment and case planning. I don't love to read off of slides. I know I've been doing that a little bit today, but really this is hearing it, reading it, seeing it, right? Ways that we're really laying that foundation to say, this is the key takeaway. We need to make sure that we have the right people doing this work so that we can ensure that we are getting the outcomes that are most appropriate to be able to help identify the people who are in our courts.
And I'll just add here that in my experience working with courts that are implementing a risk need tool for the first time, what I have found is crucial to this process is that all the team members understand at least the basics of this theory, because we can already understand how you run into problems when you use words like high risk, high need. For individuals who don't know the context in which we're using those words, it can lead us to make decisions. It can take us out of kind of the lane that we want to be in, and that's what we're really going to talk about in a few minutes. I'm going to break down risk, need, and responsivity into each of the component pieces. But if you don't have an understanding of what it means when I say high risk or what it means when I say high need, that can cause confusion within the team. And we've seen in cases where teams will say, well, we don't want to take this person if they're high risk, not realizing that that actually is the population that we best serve. The research tells us that that's the population we best serve in these adult treatment courts.
Thanks, Kelly. So what about our professional judgment, right? We've been doing this a long time, maybe. We know who's been in our court. We feel like we have a good idea of who has been successful before. And we start using a screening tool and we think, oh, that person isn't a good fit. That person should not be here. This doesn't fit with what we have. So the best practice standards are very clear about this, right? There are times when we think, oh, I know better. But honestly, and data show that that is not the case. So professional judgment in predicting a person's risk for recidivism or likelihood of success in community corrections is little better than chance, 50-50, toss a coin, right? We think we know better, but the data show over and over that that is not the case. If you use a standardized risk assessment tool, that's accurate about 65 to 85% of the time. Again, not 100% of the time, nothing is ever going to be that, but much better than if we're flipping that coin and getting people into here. Why is that? We think we know, right? We're doing this, we're professionals. But there can be a host of confounding factors, including implicit bias. We don't realize that it's there, and cognitive errors in the way that we make our decisions. It happens to us. And this can include things like decision fatigue, right? We know that we have a lot of people that we're working with every day. It can be exhausting. We are tired. We look at it, we think, nope, this person's not going to work, right? Confirmation bias. Sometimes we've said, well, I've seen this person before. I've seen the exact match of this person before. I know what's going to happen here. And we're going to say that fits with what I already know. Not the case, right? And then the saliency bias. So sometimes there's things that stand out that are triggers for us that we don't realize are really confounding the rest of the data that we have. And so that's why if we rely on this tool, we're able to say, okay, this is the outcome that we have. That takes those biasing factors off the table. And these are the studies, right? Again, we're going back to saying, we're looking at huge data sets here, far more individuals than we see in our treatment courts across the country, essentially, right? And we know that these studies show that when we use these standardized risk assessments, it significantly reduces racial and ethnic disparities in probation conditions, detention decisions, based on our professional judgment. And if we take standardized test information into account in team decision-making, it helps to counteract misconceptions because we might have cultural limitations, right? But the cultural limitations in the instruments, that is less than if we're making those decisions on our own, right? We're reducing implicit bias by using those instruments. So professional judgment, we really want to rely on these tools that we know have worked in large data sets. And if for some reason we are overriding assessment results, it should be documented, it should be specific, and it should be articulable, not this person isn't a good fit.
And Colin, we have another question that I just wanted to quickly address before I start talking about R&R theory. So first, how would you address having a prosecutor who frequently passes on cases that other drug courts likely would accept? That's definitely a longer conversation and something that we can talk about potentially on an individual basis. But first, I'd say let's talk about what the education is, because as someone who was a former prosecutor, I did have frequent conversations with my colleagues who would tell me that they weren't going to put someone in drug court when I could clearly see that on our assessment tool, this is actually the person who would benefit most from being in a drug court. So part of it is making sure that we are using the same type of language and really understanding what it is that is limiting their perspective. So is it that they hear high risk and they're saying this person's a risk to public safety, this person is dangerous, not realizing that that's not actually what the tool is telling us. So I'd start breaking it down there and figuring out exactly what it is that they're not understanding about why these individuals would be appropriate for our court. And depending on the individual you're talking to, that might be something where you need to bring them facts and figures, research articles showing that we actually want these people. You are going to get better results. We're going to use our resources better. And we'll talk about this throughout the presentation, but you're going to use this, this person actually will benefit more than the low-hanging fruit of someone who maybe doesn't have a criminal history, first arrest. They might not benefit in the same way that someone who looks high risk, high need would benefit from our treatment program. Anything else you would add to that, Colleen?
No, I think that was great, Kelly. And
Okay.
I'll hop in for Frankie's question. So it is interesting in that we said, what role do people play? And we didn't specify necessarily. There are things, and we'll talk about it at the end. We have additional trainings and pieces to R&R training in Washington that are coming up where we'll dive into some of these roles more specifically. But for peer recovery support specialists, peer support workers, recovery coaches, it might be, it depends on how your court is set up to what role you are going to play. Generally, you would not necessarily be the one that is determining whether someone comes into treatment court as far as determining those, the folks that are targeted, right? But you might be doing a screening depending on the way that your training occurs, depending on how that is set up for your court. But definitely later on, when you're working throughout the treatment court, there are ways that you can offer supports to people that have been accepted into that court.
And we've talked, we talk about R&R and usually really focus on the first two, the risk and the need. And that's what we've really talked about so far. But I'd really say, think about those roles as being necessary for the second R, responsivity. That's how we take all of this generalized information and make it individualized to the person in front of us. And I'm going to talk about that as I start to break down R&R theory, which we'll do right now. Okay, but first we'll start back with Danielle and get some more information. So now we're finding out that she does have previous charges, including shoplifting, criminal trespass, and theft in the third degree. We know she is 23 years old, and she does not believe that she needs treatment for a substance use disorder. And a little additional information about her criminal history. These have all been charges that were either reduced to be violations. She doesn't actually have any misdemeanor charges on her record, or misdemeanor convictions on her record, but you can see these charges and arrests prior to her entering your treatment court. So we're going to ask again, based on what we know so far, would you expect Danielle to be high risk, high need?
And we were kind of mean on this one. We didn't put an I don't know, so you have to choose.
And we're also very aware we're giving you limited information, but it is part of the reality of what sometimes happens in courts as we're trying to figure out who our potential participants are. Sometimes very little information is given and we make decisions based off of that. So we're really going to highlight throughout this why additional information, these R&R tools, can help us make the most informed and targeted decisions about who would benefit from our adult drug courts.
Okay, last call for response. Yes or no? What do we think about Danielle?
All right, we are almost completely split down the middle. We have 53% saying yes, she's going to be high risk, high need, and 47% saying no, she is not. All right, so let's talk about R&R theory. So what we want to talk about now is really the theoretical underpinning that we need to understand if we're going to be using these tools. We'll talk about the tools and how to use them in case management in a little bit, but we want to make sure that you really understand what we're talking about when we say R&R theory. So this model is rooted in behavioral psychology. This is primarily in the social learning theory, which tells us that people learn behaviors, values, and attitudes by observing others. And we have decades of research that have suggested that rehabilitation and recidivism reduction is achievable through appropriate court-based interventions. We look back to see that these database tools have been used in prediction dating back to the 1930s. And they have been used more and more in our recent history. There was a period of time in the criminal legal field where the prevailing belief was that nothing works to reduce recidivism. There was a very influential paper written that was quite literally titled "Nothing Works." We have moved past this and now have seen a shift from the nothing works attitude to trying to answer the question, what works? So who do we need to target and what do we need to target if we want to reduce this recidivism risk in the individuals that we are coming into contact with in the criminal legal system? And one thing I always like to remind people about R&R theory is that this is a criminogenic theory, so about what makes people commit criminal acts. That is about the criminal legal field in general. This theory is not just about treatment courts, but we do use it in research and in our practice to see how it specifically applies to the work that we do in treatment courts. So here are 3 core principles. First, the risk principle, which tells us who to target. So we understand through this theory that criminal behavior can be predicted by criminogenic risk factors, and we will talk about what those are. And these factors all combine together to tell us what level of risk someone is for re-arrest. And we're going to really focus on the fact that I've said arrest here and not conviction. Research tells us that intervention is the most effective for our treatment courts on high-risk individuals. So we're going to use this information to figure out who we should intervene with. Next is the need principle, which tells us what to target. So what criminogenic risk factor should we be targeting to have most effect on our participants? For our dynamic factors, the ones that can be changed, we can reduce risk by affecting those factors within our participants. And we're going to talk about all those factors in a few minutes. And then finally, we have responsivity principle, which is how to intervene. So this is where we start talking about tailoring our interventions to the individual. The risk and need principle are based on these large data sets of past performance and behavior that we use to predict future outcomes. But of course, we as treatment court team members want to make sure that we are treating each individual for their specific needs. So that's our responsivity principle. That's where we take all this information we have and start detailing it to the person that we're actually working with. And it's really important to remember that R&R theory, especially the risk and need, are the places we start. They are not the answer or the end of our assessment. They are just the beginning to get us understanding where our case planning, where our court supervision planning needs to go. This theory has been studied extensively in general court populations, and we know that tests on this model, research on this model, consistently demonstrate that clinical and court interventions are most effective when they are proportional to the offender's risk of reoffending. So what is our participants' risk level? When they specifically target needs related to recidivism, so our need principle, and when we respond to each individual's unique clinical, developmental, and social circumstances, our responsivity principle. Now, implicit in the idea that this works and the research that we have is that the team in general understands this tool, that they're using a validated assessment tool that is providing reliable data, and that this is used to actually tailor the interventions that we have for the individual in our treatment court. All right, now that we've talked about these principles in general, we're going to talk about them each individually. Okay, first, risk. We really want to be careful when we use the word risk. If it was up to me, I would be changing the word. We would not use risk because I think that it can be a little confusing, especially in a criminal legal context, because we use the word risk in a lot of different ways. And even within our treatment court team members, we understand that sometimes we could be talking about clinical risk, which is very different than the R&R risk that we're talking about today. Risk in this context means the likelihood of rearrest for any charge. So please note that this is for arrest, not conviction, and for any charge. So if I have someone who I'm saying is high risk, that does not necessarily mean that I think they're coming back with the same charge. They could be coming to me with a felony charge and the rearrest could be for a misdemeanor. I can't tell you from an R&R tool what I expect them to be arrested on in the future, just the likelihood of this happening again. While you may consider and should consider things like clinical severity, current charge, while you're making decisions about the case, these R&R tools that we're talking about generally do not give you that information. They also are unlikely to tell you about failure to appear or risk of violence or dangerousness. There are tools that can be used to give you information about failure to appear, about risk of violence or dangerousness, but those are not the tools that we are going to be talking about today. Okay, so how do we measure risk? There are two types of tools that exist for our treatment courts to use to figure out someone's R&R levels. First, we have static tools. These only assess for unchanging factors such as demographics and criminal history. These can still be extremely accurate as all of our tools primarily are based on this part of the information. But the dynamic tools add in these changeable dynamic factors that also research shows us are statistically related to someone's higher or lower likelihood of rearrest, the recidivism rate. And we use those, I prefer to use those tools in our treatment courts because that gives us something to work with. Again, a starting point to start discussing where we can intervene with individuals and creating a treatment plan based on their individual needs. So let's talk about these central predictors of recidivism risk. So these factors are our criminogenic factors that we are looking at to figure out someone's risk level. The first two are criminal history and demographics. And as you can see, these are going to be our static factors. And that means they're unchanging. It is unlikely that we're going to have someone in our court for whom criminal history or demographics will significantly change while they are in our treatment court. Those are going to be unchanging factors. Then we look at our dynamic factors. These are criminogenic need areas. So even though these are going to add up to risk, we're going to call our dynamic factors criminogenic need areas because these are the areas that are statistically related to someone's risk of recidivism, but also are areas that we know that we can have interventions in as a treatment court. So these include the antisocial beliefs and attitudes, impulsivity, antisocial networks, employment, education, substance use, leisure activities, and some tools include housing, some do not. When you look at all of these dynamic factors, the other thing that I like to think about when I'm talking about case planning is how can we make sure that we are building protective factors into the individuals who are participating in our treatment courts. So how do we take all of these areas that we know are going to impact whether or not they're likely to have future criminal arrests and intervene and really build those areas up so that they have strength in those areas. So how do we make sure that their employment, their education, impulsivity, what are we addressing in their case planning if we know those are the areas that they need assistance in as they move through our treatment program? The distinction between these static and dynamic factors is really important in our criminal legal practice for a number of reasons. First, the static factors, so our criminal history and most specifically age at arrest and gender are typically the strongest predictors of criminal behavior. So those short static tools will use just that information and still be able to yield a relatively accurate risk calculation. But as I said, these short factor tools don't really help us as we're making help our larger goals of having decision makers get more information about the individual in front of us. Okay, so now we're going to talk about the need principle. Again, need tells us what to target. What are those criminogenic risk factors that are dynamic, changeable, that we should be intervening with? Because if our goal is to reduce recidivism, it's important that we target the factors that drive recidivism, the factors that predict if someone will be at higher risk of rearrest. The terms risk and need are often used interchangeably, and we really want to make sure we're not doing that when we're talking about R&R tools and when we're informing our team members about R&R tools and assessments. So again, a criminogenic need is simply a risk factor that can be changed, also referred to as dynamic risk factors. There are many needs that your participants are going to be coming to your court with. And not all of those are going to be criminogenic. So that list I just read off, I'm sure you're already thinking of a bunch of needs that you see in your participants that weren't listed there. And we're going to talk about why there is a difference between criminogenic needs and needs in general. So non-criminogenic needs can include trauma history, mental health needs, medical needs, but while these do not directly correlate with our risk of rearrest, we also know that they, if not treated, they can interfere with our ability to address those criminogenic factors. So this is all to say we know there are specific factors that we want to ensure we're targeting because we know they are going to raise someone's risk of recidivism. But at the same time, we also want to treat these non-criminogenic needs because we are coming to this work with someone who is a holistic person. We're not treating just those little factors on a sheet, but an individual in front of us who is complex with many needs. So first, we treat because ethically, that's what we should be doing as treatment courts. We're not going to take someone in and say, well, we are a drug court, so we're going to ignore all your trauma, we're going to ignore your mental health needs, and just focus on substance use. Additionally, we know that that also probably won't work because we can't just treat a very specific part of an individual and expect change to work. We need to think about these criminogenic needs as part of the problem that we're solving with our participants, but not as the only thing that is going on in their lives. So this sometimes comes as a surprise to people. I think it's becoming more and more common to understand that mental illness is non-criminogenic. There's no causal link between mental illness and someone's likelihood of committing criminal acts. So where is our disconnect? Even though we know that this is not a central risk factor, one of those criminogenic need areas, we know that addressing mental health needs is going to be crucial to ensuring success in our programs. So where do we put this? We put this in our responsivity factor because, again, R&R theory is based on these large data sets that give us large predictions that are usually accurate, but we can never say are 100% accurate. So we need to take that information and filter it into the individual to ensure that we are doing what is right for the specific person in front of us. The risk and the need give us a place to start. They give us an idea of who will be best at succeeding in our courts, who will most benefit from the interventions that we have, but it doesn't mean that that's the end of our conversation. It really is the beginning. So this is a chart showing responsivity assessment and case planning from SAMHSA. And I like this because it really shows you that we're going to be doing this work throughout someone's time in our treatment court. A responsivity need, any of those things that we want to address really early on are things like stabilization interventions. So if you have someone entering your court and they need detox, they have very immediate mental health needs, they need housing, we all know that those are barriers that could stop someone from engaging fully in our treatment court. We have to address those before we move on to anything else. Or there's going to always be a blockage there. There's always going to be something that's going to stop us from being able to get to deeper issues. So we know that we want to start with those stabilization interventions. And of course, it can include more than is just listed here. And I think that this chart is probably very familiar to most of you who do this work on a day-to-day basis. When I talk to people who are doing case planning, this is what they're already doing, even if they're not looking at a chart that looks like this. Then we can move to the criminogenic needs. So all those criminogenic need areas, those dynamic risk factors that we talked about. Now we can start addressing those and really targeting our case planning to the things that we know will affect someone's risk level. Then we move to maintenance needs as well as remaining needs as we're starting to move this individual out of treatment court, making sure that we've established all the things they need, life skills training, overdose prevention, long-term recovery services, making sure that the individual is prepared to leave us in the best possible way so that we have given them the skills and the protective factors to allow them to be successful when we are no longer treating them within our treatment court. All right, we're going to go back to Danielle. So a little bit more about Danielle. So she is the oldest of 2 children, raised by a single mother with a history of substance use, who died in a very public drunk driving accident 5 years ago. Knowing this information and what we've talked about previously, would you say that Danielle is high risk, high need? So does any of this information change what you initially said in vignette 2?
Okay, I see some responses coming in. A couple more seconds here. All right.
All right, we're having 81% raised as yes, and 19% of folks saying no. So that has definitely changed. We're seeing a lot higher risk, higher need classification for Danielle after the information that we just provided. Okay. I don't see any questions in the Q&A currently, but we're going to start moving on from the theory to talking about why it's important to measure risk. So if anyone has questions about the theory itself, please feel free to start dropping that in the Q&A and I'll make sure that we get to those answers. Okay, so if we understand R&R theory, why is it so important for us to be measuring risk? Why do we want to be using these tools in our treatment? So first, social science often confirms what we as practitioners already know. So for example, a lot of us intuitively understand the importance of criminal history in predicting future arrests. So we could see someone coming into our court who has a very long rap sheet and say, oh, I think they're much more likely to get arrested again. And our research does actually confirm that. People are more likely to be rearrested when they have a longer criminal history. But in other cases, we see that science contradicts common assumptions. So validation research in our field has consistently shown that the presence of a diagnosis for mental health needs or mental illness is not a significant factor in predicting future criminal behavior. As I said, I think that's becoming more common knowledge, but it is definitely something that for a long period of time, and it still exists, an idea that those people would be higher risk. So actually here, the research challenges our innate belief on what is going to make someone higher risk. So on the balance, using this actuarial data-driven risk models tend to outperform the judgments of individual practitioners, including clinical professionals. So the rationale behind why we want to continue to use these tools is that they offer a potential for helping justice agency players, actors, make more informed decisions. Again, this is a starting point. It's a tool that is supposed to be able to help you make the best possible decisions when you're deciding if someone is appropriate for your treatment courts. Okay. The intervention and risk principle. So I want to talk here specifically about the fact that the risk principle tells us we should assess for risk and vary the intensity of intervention. And this means our court-based intervention by risk level. And when we talk about intervention here, I want to be very clear that I am not talking about what should be happening in their treatment plan. That's going to be different, and they're going to use different assessments. A risk need tool can tell you if someone is at high risk and high need, and it could include a need for substance use disorder treatment. But even if you're using a tool that specifically flags those areas, the CCAT is an example of an R&R tool that flags needs. Even if you're seeing a flag for this person is high need for substance use treatment, that doesn't tell you what treatment they need. That's where we turn to our treatment professionals to do more specific clinical-based assessments to determine what those needs are. Again, thinking of this as a starting point, not an end point for people coming into our treatment courts. So first we have higher risk. We want to provide our most intensive interventions to those individuals. So our research tells us that people who are high risk and high need coming into our treatment courts are going to be more successful. They're going to be the ones who benefit most from more intervention, more management, more supervision. For lower risk, we want to give less intervention. And sometimes this can be confusing and not really what people assume is going to happen when we intervene as a treatment court. So let's think about why lower risk individuals could actually be harmed by intervention. So I've seen before in courts where you have individuals who are coming in, maybe first or second arrest. They don't really have a criminal history. Their need levels aren't that high, but we say, we don't want to see this person back. They're young. This is a first chance. We're going to throw everything we have at them. They're coming to court as often as we have court. They're going to every service we can provide. And we add on all of those court-based services that we have available for this individual. What we need to start remembering is that actually can be harmful. Because when we're thinking about all of those criminogenic need areas, we actually want to make sure we're building them up and not breaking them down. And we always, as a court system, have the potential of bringing people too far into the system and breaking down those already built protective factors. So let's think of some ways that this could happen. If you have someone coming to court very frequently and they don't really need it, we could be interfering with their work and school. And those are criminogenic need areas that we want to keep built up. So we've already seen a way where we could start breaking that down by having them come to court so frequently. They're going to have to start missing school or telling their employer that they're not able to come into work. So we've already broken down something that was built up for them. It increases their contact with higher risk peers. That's another thing that many people have seen in their own practice, is that you see an individual who's lower risk, new to your court, and they're sitting in the back talking to someone who's maybe been there for quite a while and you have concerns about. The sharing that happens between our lower risk and higher risk peers tends to create higher risk in those individuals who came in lower risk. So we always want to be careful about exposing our lower risk individuals to other participants in the system. It's not going to be something that we can always avoid, but the more that we're allowing them to engage in their pro-social activities that they already have built outside the court, the better for, again, building up those criminogenic need areas. Additionally, there can be stigmatization. It can produce some psychologically damaging effects. Think of someone who's going into a group setting where everyone's talking about hitting rock bottom and having used drugs for a very, very long period of time in their life, and all of the ways that's impacted their life. And you have this individual who's very new to drug use and maybe hasn't seen those impacts yet. It can really start to create this feeling that they don't belong, that this isn't useful to them. And then they potentially stop coming. They stop interacting in the way we need them to interact. And what do? We start sanctioning. So we're pulling them further into the system because they're feeling excluded and not like it's working for them. They're feeling like this is not something that is actually benefiting them. And they might be right. It might not be the right situation for them. So these are all potential ways that we can see that having an individual who is lower risk and bringing them too far into our court system can actually have damaging effects. So what happens when we disregard the risk and need principles? Our best case scenario is that you're depleting scarce resources. So if we know that high risk, high need individuals are the ones who will most benefit from our programming, and we're taking low risk, low need people, it's not that it won't work for them. It might be fine. Best case scenario, they get through our program well, they graduate, but we haven't really changed their risk level. They were already not someone who we expected to see get rearrested. They were already someone who probably could do a lot of these services voluntarily or had these areas built up in their lives already. So we've just used all of our resources on someone for whom it's not going to have an impact. And that's what the research really shows, is that if we throw all of these resources at people who are lower risk, we just don't see the same impact because it's not really going to change their level of future risk. The worst case scenario is that they're getting inappropriate treatment or they're increased or an inappropriate level of supervision. And we actually start seeing that break down some of the things that we want them to keep strong that they already have going on. So Yes, you can over service an individual who is in your treatment court. And we see this in the best practice standards where they note that requiring participants to receive unnecessary services wastes time and resources and can make outcomes worse by placing excessive demands on participants and interfering with the time they have to engage in productive activities. There's also research evidence that shows that participants can become resentful or anxious if they continue to be sanctioned for failing to meet what are excessive or unwarranted demands. This is sometimes known as ratio burden or learned helplessness. And what we see is that under these circumstances, the behavior fails to improve and participants may leave treatment prematurely. So all of this means we really need to think about if we can't articulate a sound rationale for requiring participants to receive a specific service, we should start talking as a team about why we are asking them to participate. We want to make sure that, again, in that when we're using the R and R, we get to that third R and talk about the individual and our responsivity. Are we really making sure that this is appropriate for the person in front of us? Okay, so what do we do with this information when we're actually in the courtroom? For our lower risk individuals, and I want to note that you're going to see different ways that that each tool will classify people. So there are some tools that will just give you a quadrant. They're high risk, high need, high risk, low need, low risk, high need, low risk, low need. There's other tools like the CCAT that will give you 5 different levels of risk and then flags for the need areas that will tell you if someone has a higher level of need. But for all of these tools, what we want to be looking at is those individuals who are lower risk should be moved out of the system as quickly as possible. We don't want to over engage them. We want to focus on those moderate to high risk individuals where supervision or case management is appropriately intensified as they're within our program. And then the final thing I always like to remind people when we are talking about treatment courts is that jail always increases risk. And we know that the harm of that intensive intervention, all those things I talked about, of breaking down protective factors, jail does that the most. And you can really think about what happens when you have someone who's potentially engaging in your treatment court and we put them in jail. It disrupts everything. If they had employment, that's disrupted. If they had been going to treatment regularly, that's disrupted. If they had education program that was working for them, that's disrupted. So we want to really be careful about our use of jail and to use that as a last resort. It's just not, it's going to be the most disruptive. It's the most intensive intervention that we have. So it should be used as sparingly as possible. And then, Colleen, did you want to talk about this slide or I can go through it?
Go ahead, Kelly.
Okay. So again, we really just want to make sure that we are being very careful about the use of jail. Risk scores should not be used to decide who is going to be incarcerated versus who should receive community sentence. That is not what these risk scores are meant to do. Even if you're using a tool, other tools that show different categories, we really want to make sure that you're using this tool to figure out if someone's a good fit for treatment court and what kind of need areas that we should be targeting in our case planning. So thinking about this as something that is going to include people rather than put people in jail or exclude them from a treatment court. Because again, we know that these high risk, high need individuals are the ones that we want to be focusing on for our treatment courts. All right, before I read out vignette 4, is there anything else, Colleen, from the chat that you wanted me to address?
No, I answered. We had a couple questions that I've answered in there specifically. If there's follow-ups to that, please let me know. I do see another question that we just got. Is there a difference in how R&R tools in theory should be used in felony courts compared to misdemeanor courts?
Essentially, no. The tools do not differentiate between whether or not you're looking at a felony or a misdemeanor charge. But if you are looking at misdemeanor cases, it's much more likely that this is going to be a case where you won't want to have it extend as long. We found that, of course, there's difficulty getting people to participate in a treatment court, if you're going to say treatment court is 18 to 24 months and the individual at most is facing a year in jail, we see some pushback with that. So we understand that while this theory is great in a vacuum, we also then have to apply it to what we're doing in real life. So it may be that you need to reduce the program length and some of the requirements when it comes to a misdemeanor court, but that doesn't change the theory. The theory still tells us that the high-risk, high-need individual is going to be the one who benefits from your interventions more. So while it's still applicable, of course, you're going to have to then start to factor in real-world implications as we are using this in the real world. Okay, more about Danielle. Again, we're going to ask you if any of this changes your guess on whether or not Danielle is high risk, high need. And I say guess because we really want you to be thinking about this as you having limited information, which often happens, and making these assumptions without using an R&R tool. And at the end, we'll talk a little bit about where we think she would fall. We've run her case through some R&R tools, and obviously she is not a real person. If I didn't make that clear, this is all completely made up by us, but running her through the system where we think she would fall when it comes to risk and need. So more about Danielle. Danielle's prior criminal charges were all from the year following her mother's death when she stayed with friends from her high school. She completed diversion programming, moved in with her mother's sister, and she and her siblings still live with their aunt. And we know that she's been living there for about 1 to 3 years. So based on what we know so far, would you say Danielle is high risk, high need?
Hey, last call. Any other responses?
Oh, we've had a change. This is interesting. Okay, we've got people with yes down to 40% and no is 60%. So something between the last vignette and this one has made people start to think a little bit differently about where we're going to be putting Danielle in the high risk, high need categories. And I do see a question, are there trainings that help improve R&R implementation using cultural competency as an example? The socio-political environment surrounding therapeutic courts could influence who is diverted to treatment versus incarceration. Yes, I think that is definitely an important part of thinking about this. Again, taking the theory and applying it specifically to real world situations. Ideally, if we were going to be using this theory in its most pure vacuum form, we'd be screening every single person with these tools because that would tell us specifically who is most likely going to benefit from our treatment courts. Of course, that's not how this works. We know that we're going to be requiring that people have a substance use disorder, something that actually can be treated in a drug court, even though that's not the only reason someone could be high risk, high need. So there's that limitation, as well as just the system in general. There are many people who want to have input on who's coming in and out of a drug court, a treatment court. This, I think, goes to kind of a larger question. Yes, that would improve R&R implementation to have these additional trainings. And that's why we started off by saying, like, this is something everyone on your team should know. But honestly, everyone in the system should know, and we know that's not going to be accurate. So yes, there should continue to be other trainings that accompany this. And you can start talking about those and how you target the needs. Because if you're seeing that what's happening in your court system is that specific types of people are just not even being considered, I think that's something to specifically target with training. And we could go into more detail about that when we know what the specific concerns are. And it really can have to do with a lot of different things. It can do with the players that are within your system. It can have to do with kind of the overall environment that you're working in. I'd like to give a more specific answer, but I really think the answer is just becomes really specific to what it is that is, again, limiting those actors from engaging with what a drug court is. And it could be that they just don't know enough about treatment courts. They don't have the trust in the system, in the court process, to think that it's going to be the best solution for a case. And it's that education might be necessary, or there could be more detailed interventions that are needed with specific actors. Colleen, anything else you would add?
No, I think that's great, Kelly. Thank you. So now we're going to talk briefly about tools for risk need assessments. And I'm saying briefly because you'll learn at the end that we will have additional follow-up webinars, not webinars, but actually drop-ins and methods to engage around some of these. But we'll talk a little bit about what the tools are out there and what they might look like. So we'll go to the next slide. So interestingly, on this slide, the question is what validated tools are available? And I want to focus a little bit on the word validated, and we've used it before. Kelly's talked about what that means a little bit. But really, when we're talking about something that is validated, it means how accurately something actually measures what it is intended to measure. And that means an entire process using large amounts of numbers, very large data sets, to be able to say, when we implement this tool, we're actually getting the outcome that we expect that we are going to get. And it involves a lot of statistics. It's not something that you are going to do in your own court, although there are times when courts are involved in testing the tool and then giving those data back to the folks who are doing that validation. So what you want to look at is whether really the outcome matches what the procedures are, what it is measuring. And that involves looking at the way it's administered, where it's administered, how accurately those ends are perceived. One of the things that we were interested in, and we've been, again, working in Washington State for a while, is saying, what are the courts in Washington using to be able to determine R&R, to be able to say, yes, these are the folks who we're targeting for our courts. I'm going to give a little bit of a plug for a tool that is out there, not an R&R tool, but a survey that is out there in your courts called The Water, where you can provide that information so that we can more clearly see who is using what tools in your adult drug courts. Some of the ones that we are aware of are the ORAS, which is the Ohio Risk Assessment System, the RANT. We know that courts are using the CCAT, and we've also heard that some courts are using maybe the LSCMI or the LSIR, which is the Level of Service Inventory Revised. The interesting thing about, I want you to look at kind of the ORAS. Many people are familiar with that or are using that. Notice that it says on there, Ohio Risk Assessment System. It doesn't say Washington, right? And that's because when it was validated in Ohio. So we know that when it was first administered, all of the data came from the individuals who were in the drug courts in Ohio. So we want to kind of recognize that and say, we're using this, we're mapping it on, but it might not be giving us the exact outcomes that we would expect had it been validated in Washington State. And that kind of harkens us back to the slide at the beginning where I gave the definitions, Washington State's definitions, to some of those different research bases. So evidence-based could mean that there could be successful replication in Washington when possible. We know that it is incredibly expensive to do validation studies. It is not something that is in the budget for courts and states generally. So just acknowledging that we're using tools that maybe aren't, that the validation wasn't done in our spaces, but it doesn't mean that they weren't validated at other points in time. Kelly, do you have anything you want to add to that?
No, nothing else I would add to that.
Okay. And using one of these tools, it doesn't mean that there's a right or wrong answer for you, right? There's not one tool that is going to be like, this is the one that everyone needs to use. In some states and in some places, that is what is being done. But going back again to saying, well, this wasn't validated in Washington State, I guess I'm not going to use it. That brings us back to that toss-up 50-50 of whether we're actually getting the right folks in our court. We want to use a tool because regardless of whether it is specifically validated for Washington, it still gives us better outcomes in that space.
And I guess I will add, said I wasn't going to add anything. These tools are all still based on this R&R theory. So all of this is based on the same theoretical underpinning, but most of these are proprietary tools. So I can't tell you specifically how they use the questions to get the risk and need scores that they're getting. I don't know exactly how every question is graded. And I don't know how the raw score is potentially changed to give you your outcome. We do know that for the CCAT that was developed by the center, and Colleen's going to talk about that in a minute. I know much more about the inner workings of that tool. But the other ones we know are all, again, still based on the theory that we talked about here today.
I muted myself. So we'll go to the next slide. And I do see in the chat, in the questions, there's a question about the CCAT assessment, or it's just written there. So we're going to talk about that now. So the center actually created the CCAT to fill a gap specifically. So Kelly talked about the tools on the previous slide. They're proprietary. What that means is that you're paying for them to use them. And we aren't able to say, how was it developed? What are the ways that all of these different criteria are weighted to be able to reach that outcome? And so looking at that, there was this shortage of tools that cover these needs, but are efficiently administered in high volume settings and allow referrals to the effective intervention. So are saying, yes, this is an R&R tool that allows us to figure out whether someone is high risk and high need without having to pay for it and having it available and open. This is something, there are different iterations of the CCAT. And when we asked in that water survey across Washington, what tools people were using, people did indicate that they are using the CCAT in certain courts. And there are different kind of iterations of what that looks like. It could be short, it could be long. And in New York State recently, there has been a move toward developing the CCAT specifically for adult drug courts in New York State and using that more broadly to try to create that uniformity in making sure that individuals are getting the right high risk, high need populations into their courts. And Kelly's been deeply involved in that process. So I'll let her comment more if there's anything else you wanted to add, Kelly.
Yeah, the CCAT, the reason that New York is using it is because it is an open source. So I can tell you how each one of the questions is scored. And we were able to combine that with their current screening program screener. So there's only one screening happening when someone enters their treatment court. But a number of the questions being asked are not R&R related questions. They're just questions that people need. My go-to example is there's a question about whether or not someone's ever been treated for tuberculosis. That has nothing to do with risk or need, but it does have to do with some of the residential program questions that the case manager will have to answer later down the road. So we combine the two so that we move a little bit away from that exhaustion of being interviewed over and over and over again to enter a program. And I see a question I think we can answer now. How might implementation of R&R differ in a prosecutor-led diversion program, which in my opinion falls under the umbrella of therapeutic alternatives? And I think here, in my experience, and if this is different, maybe we should be treating it differently. But in my experience, the prosecutor-led diversion programs tend to be lighter touch. They're not usually as intensive as our adult treatment court programs. So actually, that's a great place to put someone who is lower risk, lower need. It's more of a quicker off-ramping. Instead of keeping them in a program that could last 18, 24 months, someone who doesn't need that level of intervention, a prosecutor-led diversion program is perfect for someone like that because lighter touch, they're still getting the services. We often see that individuals who are lower risk, lower need are better able to handle voluntary programming. So just getting them attached to services can work better than getting them in a much longer term program. It also allows for folks who don't have a case that would lead to kind of the level of criminal involvement that maybe a defense attorney would want to see before entering their client in a treatment court. It's kind of a step down from that, so that we still have somewhere for individuals to get referrals to these services, to get some interventions. But again, it's not at that higher level of a treatment court.
And I think Kelly mentioned it earlier, that's that responsivity piece, right? So you do the screening, you determine where they fall on risk needs, and then you say, okay, where is the best placement based on what we now know about them?
All right, a little bit more about Danielle. At the time of the current charge, she had been working at IHOP for 3 years and was pursuing culinary arts certification at college, at Edmonds College, after receiving her GED. She was a recreational user of cocaine with her friends at IHOP. Again, based on what you know so far, would you say she is high risk, high need?
Okay, we'll give people just a minute to last call on Danielle.
All right, yes has decreased again. We're down to 14% yes and 86% no. So 86% saying she is not high risk, high need. All right, and now I'm going to turn it back over to Colleen.
Okay, so now we've gone through and we've talked about the theory, we've talked about what our target population was, but then what do we do if we say, well, adult drug courts are for high risk, high needs individuals? What about our low risk individuals who are getting these charges? Does that mean that we cannot serve them or that we don't serve them? So let's find out. Sometimes there are exceptions to who is in our treatment court. And this comes directly from the standards. And again, the standards are really clear about our adult drug courts are generally high risk and high need. But what does that look like? Sometimes prosecutors say, nope, I won't take individuals who are a certain charge level or have a certain risk, right? But it doesn't mean that we can't provide treatment. It just means that it needs to be tailored differently so that we're not harming the individuals in both of those tracks. So from the standards, a program should develop alternative tracks with modified treatment and supervision services designed for persons with lower risk or need levels. If a treatment court does develop those tracks, this is really, really important, those participants are with different risk and needs levels are not served in the same counseling groups, residential programs, recovery housing, or court status hearings, right? It does not overlap. There are different tracks. It's like trains that are running separately, right? They're not meeting in the middle. If trains on different tracks do meet in the middle, it's a crash. It's not great. We don't want that to happen.
And I'll also note here, I know there's some people listening who the first thing you just thought was, well, that's impossible. We know that especially in smaller programs in more rural areas, we don't have the same level of services available. Someone might have to be in the same programming. They might have to come to court on the same day. But really looking at this and seeing the ways that you can separate these tracks as much as possible. This is where we were talking about those higher risk peers and those interactions and separating it as much as possible. And again, this is where we take the theory and tell you what the best practices are and the theory kind of in a vacuum, but also acknowledging that this isn't going to be 100% possible for everyone. So it's really important if you are developing tracks to think about where you can make those differentiations, where you can make it something that works for your program. And I will say multi-track systems are becoming much more popular than they were, I'd say, even like 3 years ago. I'm seeing a lot of national trainings surrounding this. So it's definitely something that is newer in our space, but there is information out there if you need more assistance, if you want to learn more about how to create these tracks effectively in your court.
Thanks, Kelly. And I'll respond to the question in the Q&A. It's not, we haven't specifically targeted diversion programs or those types of programs, but it doesn't mean that they can't watch this, they can't learn from it, and that they can't attend subsequent trainings that we are doing. So absolutely, because again, we're recognizing that these are individuals that would still need to be served. Okay, our next slide. So again, this is somewhat of what we've talked about already, right? But looking at these modified services, it could be lower intensity, lower treatment. What does that look like? Well, we can see that the outcomes are showing that if drug courts and DWI courts reduce that frequency of court status hearings or counseling sessions, there are better outcomes. So even with, maybe we don't have all of the resources, but we can say, come less frequently, right? We're not over programming you. We're not knocking you out of the support and services that you already receive. And we're just giving you less of something because that is all that you need. It's the responsivity piece that we're able to build in. We'll go to the next slide. So the data are slow moving forward. Well, I'm not going to say that. I'll take that back. They're not slow, but it takes a long time for data to actually get out here because we want to provide best practices, right? We want to say this is what works on a large scale. And so if we're looking at this, the data that we have do really demonstrate that there is support for implementing these tracks according to risk need. So this is an example. This I've linked in this slide, a link to the actual survey study if you want to read it. But it says specifically, when supervision and services are provided based on participants' individual risk and need, this results in a significant increase in public safety due to lower criminal recidivism, as well as substantial cost savings to the taxpayer. Apologies, this is the fun of webinars. Kelly, I might have you jump in here for a second.
Yeah, sure. I'm pretty sure I know that Colleen's dogs are barking in the background, so I will take over. So best practices for tracks in therapeutic courts. So really, again, thinking what is the purpose of having these multiple tracks? If you're going to start doing this in your court, you really need to start specifically thinking about why you're doing this and what effect it's going to have on your participants, and what are the needs of participants in these different tracks. So we should be talking to our supervision agencies, treatment programs, and seeing ways that we can differentiate where people on different tracks are falling to the best extent that we can. But it's important to have that conversation. That's another reason why making sure the whole team understands this risk need responsivity theory is important, because you want to be able to have the conversation with these individuals and say, this is why it's important. We know all of this about treating high risk, high need individuals versus low risk, low need individuals. So we need to work together to make sure that our interventions are the most effective and we're using our resources in the way that's going to be most impactful for our court, for our participants. If you can separate into court status hearings, that's really important as well. I've seen courts do this where some of the lower risk individuals come and are the ones who are first go through the court, and then there's a later session for our higher risk track. Something like that can happen if it can work if you only have one day that you're able to run your drug court. And then we want to make sure that we're using the correct sanctions and incentives when we're talking to our participants. Colleen, you want to jump in here on this part?
Yeah, so one of the things that we want to look at is whether if you're sanctioning in a different way, right, depending on what is happening for individuals. So, sorry, hold on a second. All right, so for instance, a low need participant might get a different sanction because they are better able to control their substance use than someone who is high need, right? Like if they are using, if their UA comes back and shows that they have positive use, right? They are going to be less likely to get sanctioned because they aren't able to actually control their substance use yet. Whereas someone who is low risk and we know that they have the ability to have more control over whether they're using substances, we don't want them to see that. We don't want them to be in the same place and say, actually, why did this person get off and I didn't, right? That seems unfair. And we know that in our criminal legal system, we are trying to base this on individual needs. We're trying to be responsive to that. And we're trying to make individuals understand that this is fair based on what their abilities are.
Yeah, and I think that that's something that's come up when I've trained courts before on using this, and especially within different tracks, is the question of, well, how is this going to be seen as fair for our participants? And the reality of our courts is that we need to be treating individuals as individuals. So while we may have graduated sanctions, graduated incentives, so we know where the sanctions are going to increase because of behavior. We've also been taught for a really long time about the difference between proximal and distal goals. So we need to be really clear about what we're using sanctions for, because if it is a proximal goal, it's something that we do believe this person should be able to achieve. And that can change depending on their risk level and where they are in their programming. Someone who's day one high risk, complete abstinence is probably a proximal, is probably a distal goal, something that they're not ready for yet. But at the very end, when they're in their final phase and they're about to complete, that should be most likely a proximal goal. And we're going to have different responses based on that, because we want to think about what our capacity, what are the abilities of our participant, depending on who they are and what point they're at in their process.
And I want to mention too here, just one more thing. We don't really talk about moderate risk, right? Like where does that fall? What does that look like? And it's hard because that is a place where more nuance is required, right? We don't want to overserve. We don't want to underserve. We really want to make sure that we're responsive to needs. So for instance, if there's a substantial risk or a substantial record of drug-related felonies, right? They might be suitable for drug court in a different way. But if it's a first time offense, maybe we've seen with a moderate risk score, maybe we don't want them in drug court. Maybe we want them in a diversion program or a different, a lower level track. So it really is, you know, if someone is on the fence, we're not really sure what that is. We want to make sure that we're most responsive and we kind of look at those different factors to be able to make the most informed outcome for that individual.
So just building on all of this to kind of sum it up, we want to use risk level to inform things like intensity of supervision, frequency of court appearances, intensity of services meaning interventions that are related to their criminogenic need areas. So how much are we involving someone in vocational programming? And this is where you really need to use that responsivity piece. Because if your individual is high need, but it turns out one of their needs is not in education or employment, we don't want to overburden them with that. And that's what we really have to keep thinking about. Are we overburdening someone who doesn't need the interventions? It can't be one size fits all for our participants. If you have someone who has had a stable and steady job for the last 10 years and they're going to continue in that career, we don't need to give them vocational training. Their criminogenic need areas likely lie somewhere else. Maybe it's impulsivity, maybe it's pro-social activities, maybe it's family. We need to determine the services that are appropriate to the individual who's in front of us. So again, remembering that these R&R tools are where we start, not where we end. This is an example of what one court that I've worked with has done using the CCAT risk scores. You'll see that there are 5 different levels: minimal, low to moderate, moderate, high, and high risk. That is how the CCAT classifies risk. We're going to use our most of our interventions, our highest interventions on the high risk individuals and reduce on the minimal risk. So you see for this court, this was a larger court that had a lot of resources. They had a pretrial calendar with monthly compliance, and the minimal risk people went there. It was very light touch, and they were not really pulled into the system very much farther. And then we go all the way up to high risk, and you'll see things keep getting added. They're going to be in drug court. They're going to be coming weekly. We're going to be looking to see if inpatient is appropriate for this individual. It might not be. Again, that's a clinical choice, but it's something that will be considered because of their high risk and the potential of a high need situation as well. We're going to be looking at employment and education. There is going to be random drug testing. And you see a lot of those things have to do with those criminogenic need areas, because when we have those higher risk individuals, we want to make sure we're really targeting those areas and building up those protective factors for when they leave our court. All right, we're going to skip to the end for Danielle. She got into treatment court and she successfully graduated. She got her culinary certificate and is working on Olive Garden while deciding next steps. What's interesting about Danielle is that Colleen and I, before this presentation, took all of the information we had and ran her through the CCAT. And what we found is she is going to be a minimal risk, the lowest risk possible. And we don't see many significant need flags for her. There are some, but not significant ones that would place her in a category I would call high risk. So this is someone who probably needed light touch. She needed a little bit of assistance completing her education, but she really was already on the track to doing it. She has a very little criminal history that would make it more likely for her to be a higher risk of future recidivism. So what's interesting is that you guys started clocking this correctly. At first, she seemed really high risk. And then as we talked about all the factors involved in what creates risk and need, we started to see everyone reducing her need level, her risk level and need level. And that follows with what the tool that we use to assess her was telling us. Colleen, did you want to say anything else about Danielle?
No, I think that really tracks. And I think it is the example right from the beginning when we say, this is why if we're doing it on our own, we might get stuck on one or two things here and think, oh, but I know someone who had this and they really needed more than they're sharing with us right now, right? It might be, well, she doesn't think she needs treatment, but she really does. But when we use the tool gives us that outcome. And so we're able to follow more precisely and lean into that, as opposed to kind of hear some of those biases that may be creeping in based on the work that we do.
There's a really good question. Does R&R factor in what the individual feels they need? Most of these tools do not factor in the individual's feelings. They're questions about needs and questions about how a person is presenting. But that's really where that second R comes in, the responsivity, because case planning should be happening with your participants. Will there be situations where you are going to say, listen, you went and got our treatment partners assessed you need a very high level of treatment. Like that is what is called for in your case. And that person doesn't want to do that. But that's part of all of our case planning. And that's not really what R&R is telling us, but that does fold into the responsivity part, where that's where you have the individual conversation. That's where the team starts talking. That maybe that's where you start involving a peer and started getting that person to the place where they understand why the intervention level needs to be so high for them, that they are high risk, they are high need, and explaining to them what that means and how these interventions can assist them. So R&R is not going to give you an answer or just tell you this person absolutely has to do this. There's no other way of going about it. It's the beginning of a conversation and starting to identify those need areas that are making your participant more at higher risk of recidivism, at higher risk for re-entering our criminal legal system. So again, addressing all of those things will be part of the conversation you have in your case planning. Anything else, Colleen?
Nope, that's it.
All right, what's next?
So what is next? When we started this project with Washington State, we said we really want to build in R&R training and not just a one-off webinar. We want to make sure that we're really building on the knowledge that you have and providing information that is most relevant to what is happening in your courts. So there are a few things that are coming up from this, and specifically for any of you that will be at the WSADCP, so Washington State Association of Drug Court Professionals, Kelly and I will be presenting a different version of this to folks specifically trying to focus on judges, prosecutors, and defense attorneys around risk, need, responsivity. So what does it mean moving from paper to practice? So please, I know most of you are not judges, prosecutors, defense attorneys, but you know them and you know that they probably need a little refresher too, right? So please remind them that this will be happening and invite them to attend if they will be at that conference next month. Then Bill,
Kelly,
go
just
ahead,
want to
Kelly.
jump in. And if you have any, again, most of the folks who are at this training are not judges, prosecutors, defense attorneys. So if there's anything that you have listened to here today or things that you would want added when we're talking to your judges, prosecutors, and defense attorneys, do feel free to drop that in the Q&A, because we'll be sure to address those if there's specific concerns that you can identify for those kind of the attorney positions within your treatment court team.
Absolutely. And then, so this is actually starting a virtual training series that we will be doing, and it will be monthly. So what this means is that we'll have topical sessions specifically around maybe a little bit of a deeper dive, about a half hour each session around elements of R&R. After this webinar, we will be sending out a poll, a question to all, or an email to all of you questioning what you think would be most important to hear about. What are the follow-ups that you need? We did a very kind of overview around many of the topics that we have, given our time constraints, but we know that you want more info. So we're going to ask what you think some of these topics should be, and we will build them in as we build out these drop-in sessions. You won't have to register necessarily. You'll have the info and you can jump on. But we want to make sure that we're really focusing on the topics that are most important to you so that you can get the most out of it. We're also holding office hour sessions. So that means on the alternate months when there's not a deep dive topic, we're just going to be there if you have questions about cases, if you have questions about tools, and we'll try to help out as needed, but it doesn't have to be about us. That can be a space where you come and talk to other people as well. So that is on the radar at the same time. It'll be the second Thursday, 8:00 a.m. Every month through next September. So for an entire year, we'll be working on this. Our timing is pretty good. We wanted to make sure that we left time for questions at the end. Does anyone have additional questions, things that you want to know based on what we talked about today? So first I'll address the link one. Yes, we will send out a link for additional sessions. We'll have a little flyer that we're in the process of making with that information. That'll go out and I'm sure it will be disseminated. I know Tessa has sent out links. We partner with both HCA and AOC. So they will be making sure that you get that information. And if you've registered for this and we have your email, we'll send that out to you too. Hopefully you won't all be Colleen Gibbons. We'll make sure that we fix that a little bit. And then I see Edred's question. How is accountability factored in with R&R implementation?
So I don't think R&R necessarily will affect how you're using accountability in your courts. That's going to continue. It might start to talk about the proximal and distal goals, but again, these tools won't specifically tell you what is a proximal or a distal goal for the individual in front of you. So you're going to, I really encourage you to think of these R&R tools as a tool, as more information as you start doing case planning, as you start deciding who's eligible for your courts. But it's not going to change how you are using incentives and sanctions. All the things that we spoke about when we talked about incentives and sanctions really have to do with stuff that you're already thinking about. How do we best use our tools to make sure individuals are successful? How do we make sure that we are sanctioning if it is a proximal goal, but we are talking about clinical interventions and other ways of helping the individual when it's a distal goal, something that we're not expecting them to be able to achieve yet. So I'd say, yes, it can help you with more information, but it's not probably going to significantly interfere with what you're already doing in holding people accountable in your treatment court. The courts use a validated risk assessment used by local community court corrections agencies. The answer is sometimes. And they're really often, the other thing to remember is that they're usually used for different purposes. So it would be very specific to what they are using. For example, one of the tools that exists is the Compass. I know that's primarily, in my experience, used by corrections, but I do know that some courts use it, and it's an R&R tool. So the answer is sometimes. It depends on the tool, depends on the use. And yeah, that's about as specific as I can be. Colleen, anything else?
And sometimes R&R tools are used for different purposes. So we are specifically, again, framing all of this in a therapeutic court, adult drug court context. There are uses for R&R for other purposes, specifically around returning to court for different points and other kind of community interaction. So in this context, we try to make sure that we're keeping our conversation around adult drug court use.
It is, though, a good question to be asking of your partners. If other agencies are using a risk assessment tool, it's always good to know what it is, and try to be able to incorporate that into the information that you're gathering about the individuals in your courts.
Thanks, everyone. Last call for questions. And again, reach out. We will send these out, I know, to everyone registered, and we'll also make sure that this recording is available so that you can share it with anyone who you think might be interested. All right. Thanks for joining us. Have a great rest of your day.